Welcome back, guys. So we're going to do part 2 to our video series. So last time we did massive bleeding of our Mouch algorithm. Now we're going to do airway and respirations. So what are we looking for airway? So is the airway secure? Is it patent? Are they able to breathe? If they're able to talk to you, well then they have a patent airway. They're securing it on their own. Now you can secure it a couple different ways. So positional. So we can do a head tilt, chin lift. We can do a jaw thrust. We can do left lateral incumbent, so they have bleeding in the jaw or bleeding around their face, letting that blood drain out. We can use adjuncts. We can use an OPA for an unconscious patient. We can use an MPA for a conscious patient. We can use a King LT for an unconscious patient. And if we had to, there's massive facial trauma, we can use a crike. Now, crike is a surgical intervention, so if you're not properly trained, I don't suggest trying that. Just go ahead and throw that out there. Now, the King and the OPA are supraglottic airways, meaning they are above the vocal cords, right? So that's supraglottis. Now, the crike and an ET tube are going to be subglottic, meaning they're through the vocal cords. Now, the ET tube is going to be your best, most definitive airway, and you can intubate in the field. You need your RSI drugs, you need the proper equipment, proper training. For our general everyday March practitioners, let's say we're not going to intubate in the field just because it's a little bit more equipment and task intensive. So if we need to do a definitive airway, they're most likely going to go ahead and crike, at least in some modalities. Next, go into respirations. So respirations. This is where we're going to assess our lung function and make sure that we're adequately ventilating that patient. So if they have any holes in the chest, we're going to seal them, seal those holes up. We're going to assess the chest. If there's an entrance wound, we're going to look for an exit wound, seal that. If they have signs and symptoms of tension pneumothorax, i.e. unilateral rise and fall of the chest, respiratory distress, trouble breathing, things like that, we're going to relieve that pressure with a needle chest decompression or NCD. So NCD is going to be midclavicular or it's going to be anterior axillary. If you don't have a needle and you have the ability to do a finger thoracentesis, basically you're going to cut like you're going to do a chest tube, stick your finger in there, blow that air off. However, as you can imagine, that's going to get messy. You're going to have a pressurized system. If there's any blood in there, it's going to blow out towards you. If you have the ability and you're in a roll 1, you're going to use O2 or BVM. Some people carry BVMs in their aid bags. Most of us do anyway. But do you carry O2 in your aid bag? Do you have solid state O2 or you're a flight medic and you've got an O2 bag or a practicing paramedic? This is where we're going to try and get those O2 sats up, get our patient to a better outcome. So once again, airway, secure. Is it clear? Is my airway patent secure? Going to use an adjunct if necessary. Respirations, seal those wounds, decompress the chest, give O2 and respirations if I need to. All right, I'm going to show you guys a little bit what that looks like on the mannequin behind me. So follow along. So we're going to go over the airway and respirations, kind of how we're going to do the hands-on portion of that. So my patient is completely sterile. There's no injuries to him. He did have that bleed. We've already taken care of the tourniquet there. So I'm going to assess his airway and respiration. So I'm going to give him a little stimulus. Hey, buddy, can you hear me? Can you hear me? Unresponsive. So from there, I know he's not talking to me, so I don't know if his airway's secure. Looking at his airway, chin thrust, or head tilt, chin lift, jaw thrust. If he's bleeding from the face, I can do left lateral incumbent. I'm going to go down here. I'm going to assess his breathing. So I'm going to come down here. I'm going to put my hand on his chest while looking at my second hand. And I'm going to be looking for equal and bilateral rise and fall. I'm going to be feeling if he's breathing on the side of my face from his nose or his mouth. Let's say I have one breath every 3 seconds, so 20 respirations a minute. So I have equal and bilateral rise and fall of the chest, or if it's unilateral, let's say he's got an injury to the left side of his chest, he's got a wound there. So chest seal. So with a hyphen, it has one super sticky kind of patch in there. For the halo, it's the brown package. It's got 2 chest seals in there. For this guy, if I have an exit wound, I open it up. I can stick that seal on there. I can use the plastic covering for it, or I can use this, tape it to the back as a 3-sided dressing. So let's say I had an open chest wound. I sealed it off. Chest wound sealed. So now what I'm going to do is just assess again. I did an intervention. Hey, buddy, you feeling any better? He's showing signs of tension pneumothorax. If he's got unilateral rise and fall of the chest, or he's in respiratory distress, or he just says, hey man, I'm having trouble breathing in one-word sentences. So I'm going to go ahead and perform an NCD. So midclavicular line, second or third intercostal space. I'm going to go anterior to his chest. I'm sorry, not anterior, but perpendicular to his chest. Put that in there. Feel that whoosh. If that doesn't work, I can go to the anterior axillary line, the 4th or 5th intercostal space. Put that bad boy in there. If I hear whoosh, insert it in. Make sure you're using your 14 gauge 3.25 needle. And you can do these things, like if you do 2 NCDs, you're not getting any air back, or you're not getting a positive basically return, just go ahead and move on to circulation. If you don't have a needle and he's got an open chest, you can use basically burping with your finger, a finger thoracentesis, If you go to that fourth or fifth anterior axillary line, go ahead and perform like you're gonna do a chest tube. Break through that chest wall and kind of burp it with your finger. Like I said, I don't recommend doing that if you guys aren't trained on it, but let's assume for the purpose of the video, all you guys are fantastic medical practitioners. So once again, airway, is it secure? What's my rate, rhythm, quality for my respirations? And then for here, I'm just gonna go ahead and assess lung sounds if I'm already here. So we got apex, apex, base, base, and then I'm gonna assess for PMI. Let's look right here on the xiphoid process, go to about 2 inches to the left. It's the apical pulse. I wanna see where that is. It should be the hardest pulse that I hear in this region. I'll put a little X there. Now the reason I do that is, let's say he does have a tension in with thorax, and you're starting to get a medius dominant shift. Either way, so if my PMI is here, and now it's here, or it's here, and it moves over to here, well, I know there's something wrong there. That's an objective finding. Hey, his PMI has moved. That means that there is pressure in the chest pushing things over. But there's a lot more detail we can go on an assessment. Like, this isn't a full RTA. After we finish the circulation and head injury hypothermia, we're gonna do an entire RTA to show you guys kind of what it looks like at speed, and kind of show you guys how in depth it really is. Like I said, if everyone in medicine has their own styles and techniques, like there's gonna be somebody out there that's been an 18 Delta for 27 years, like, oh yeah, don't do it that way, or some dude who worked for some organization that's 3 letters and be like, oh, we actually do it this way. That's fine. Like, everybody's got their own style and technique. Medicine's always changing. There's always new stuff coming out there. Some people have, cutting edge stuff. I'm just doing the basic March algorithm that, NAMT puts out. There are some things that I do completely different whenever I'm working on my patients. It's just, this is a baseline March assessment, just so you give you guys kind of what a way is, and then you guys can build from there. It's just like shooting. Everybody's got their own way they shoot. Like, there's a couple different draws out there, but everybody kind of gets what works for them. So if you guys have any questions, comments, concerns, just hit me up. I'm always wanting to learn new stuff, and if you guys have any techniques that you feel will be applicable, dude, let me know. Like, I'm always willing to be a student. But I appreciate you guys. Thank you very much.